Hello, my name is Jeremy. I'm with Faithful Guardian Training Center, and today we're going to be talking about chest trauma. So I'm going to take a moment and I'm going to talk specifically about pneumothoraxes and tension pneumothoraxes. So a pneumothorax is literally air in the thoracic cavity. It's going to build up in the pleural space, which is going to be outside of your lungs, but beneath your actual chest wall. And so what this does is you have your lungs, which is going to be right here, and this is going to be your chest wall. So what you have is every time you breathe in, you have a little bit of air that's actually going to end up getting built up on this chest wall. So as your lungs continue to work, you're increasing the amount of air between your chest wall and your lungs. And so what this is doing, this is increasing your dead space, because a lung that is getting compressed, it's not able to participate in gas exchange as well as the other lung is while it's not getting compressed. So again, you increase your dead space. And the fix for this is going to be a needle thoracostomy or needle decompression, where you actually take a 14 gauge angiocat. There's multiple brand names out there, and you want something long, such as a 3.5-inch needle. And so what you will do is you'll find your midclavicular line, okay? And so you have left and you have right, or you have your left and you have your right. So if you are wanting to do a needle decompression over here on the right side because you are suspecting a pneumothorax, you would go to the second and third ribs, and you would go into the second intercostal space, midclavicular. So you'd essentially find the nipple line, and you would draw that straight up and down. You would go right there in that intercostal space. And you want to, something that I have found is you want to go over the rib. You do not want to go under the rib. You may remember from the previous video where I talked about water flowing under a bridge in this example. Okay, so water does flow under a bridge, and your blood vessels do flow underneath your ribs. So for example, if you have your rib, you have your vessels that all lie underneath it, and over top of it you have an empty space, and we want to enter that empty space so we're not causing any vascular damage. So you can also look at this as, monsters are under the bed, and if you aggravate the monsters in the bed, you're going to get aggravated at night, okay, and you're not going to be able to sleep as well. So if you stay on top of the bed, you don't get aggravated, the monsters don't bother you, which means that your patient's not going to decrease in their blood volume. You're not going to lead that potential hemothorax by chance. So building on the pneumothorax, we actually have the tension pneumothorax. Now, a tension pneumothorax is a pneumo that has developed to the point where it's actually compressing the cardiac muscle. Okay, and so again, what you're going to see is you're going to see JVD, or jugular vein distension. Okay, and so what this is you're actually going to be able to see their jugular veins build up. Okay, and what this indicates is that there is a blockage somewhere downstream that is preventing blood from returning to your heart. Okay, and again, this right here is jugular vein distension. Okay, so you have a decreased the amount of blood that's able to return to the heart. Okay, the reason that this works in the tension pneumo is because it actually is going to compress the vena cava, and if it compresses the vena cava, you're actually going to decrease your preload. Okay, and you increase your central venous pressure. Okay, and your central venous pressure is what you have right there in the vena cava. Okay, and so with that pressure being increased, you have a backup of blood flow, and you're also going to see this in patients who have right-sided heart failure. And so what this is further going to do is, since it decreases your preload, it decreases your cardiac output, because you remember, preload is a prerequisite for cardiac output. Okay, and so another aspect of a tension pneumo is where you are going to have tracheal deviation. So for example, right now my trachea would be midline. If I were to push my trachea over to the left, okay, so you have the midline, it is no longer midline, it is favoring my left hand side. What that means is that I have air building up in my thoracic cavity that is shifted my entire airway anatomy over to a side where there's not air building up, right? And so again, the fix for that is going to be that needle thoracostomy. Okay. The second place to perform a needle thoracostomy that's not midclavicular is going to be mid-axillary. Okay. And that mid-axillary, you want to go in that fifth and sixth, find that fifth and sixth rib and go in that fifth intercostal space. And again, you want to take your needle, find your rib, and go over your rib. Okay, because we do not want to go under, because then we agitate the monsters under the bed when we've disrupted the flow of the river that was underneath that bridge. Okay, and so what that's going to do is that needle, as soon as it punctures and you take your needle out, throw it in the shark container, you have this piece of plastic that's going to be stuck inside of your chest wall, and that's going to allow for air to be able to escape as that air continues to build up. All right? And so again, tension pneumothorax, absent lung sounds on the affected side, you're going to have JVD due to the increased central venous pressure, and which is going to cause a decrease in preload, which decreases your cardiac output, and you're also going to have a tracheal deviation in a tension pneumothorax. All right? And that's about tension pneumos and pneumos.